Hello, today we are going to look at heparin-induced thrombocytopenia. We will discuss the pathophysiology behind it, manifestations, risk factors, the two different types. We'll talk about some monitoring and laboratory data associated with diagnosis and treatments of heparin-induced thrombocytopenia, or HIT. HIT is an immune-mediated drug response caused by heparin-dependent platelet-activating immunoglobulin G antibodies that heparin binds with platelet factor 4. The binding leads to the development of a highly reactive immune complexes that activate the platelets. Once the platelets are activated, they release procoagulants and PF4, which neutralizes heparin and increases thrombin generation. These antibodies damage vascular endothelium and promote thrombosis and a rapid loss of circulating platelets. If platelets are decreasing and patients are experiencing symptoms of a thrombotic event, discontinue any heparin and notify the physician. Patients are at risk for DVT, loss of limb, pulmonary embolism, cerebral thrombosis, and myocardial infarction. Bleeding is rare, but can be a manifestation of HIT, likely due to increased tendency to form clots despite thrombocytopenia. Some risk factors for HIT are heparin use, a duration of more than 7 days. Exposure of heparin does not have to have occurred recently. HIT has manifested up to 100 days after a patient's exposure to heparin. Thromboprophylaxis treatment in post-surgical patients and exposure to unfractionated or low molecular weight heparin and simply being female increases a patient's risk for HIT. HIT is characterized by reduced platelet counts and an increase in thrombotic events. Type 1 HIT is not mediated by the immune system, but is rather an interaction of platelets with heparin that causes clumping. Usually, patients will not have platelet counts less than 100,000, and it will resolve in 48 to 72 hours. Type 2, on the other hand, is immune-mediated and often goes unrecognized and is highly associated with adverse patient outcomes. 20 to 30% of patients die, and an equal amount of patients are left permanently disabled due to complications of HIT. Patients must be closely monitored, including vital signs, heart and breath sounds. Circulation, including bilateral pulses and skin, should be assessed frequently. Follow order sets and protocols for lab monitoring for patients on heparin therapy or have recently been on heparin therapy. Always remember, what can make you bleed can also make you clot, and vice versa. Treatment for heparin-induced thrombocytopenia is based on the underlying cause of HIT. Heparin therapy and any other heparin-treated lines should be discontinued immediately, and drug therapy with direct thrombin inhibitors will be initiated. Each case is different, but a drug often used is argatroban. Surgical intervention is needed to directly treat thrombosis in many cases. Heparin-induced thrombocytopenia can be fatal, and patients on heparin therapy must be closely monitored. Know the signs and symptoms and frequently assess for them. Be sure patients' baseline labs are obtained prior to the initiation of heparin therapy. Monitor laboratory data and ensure that when heparin therapy is ordered, that physicians are using the heparin order set and following protocol. As previously mentioned, HIT often goes unrecognized and undiagnosed. 12 million patients are exposed to heparin annually. Up to 7% of these patients will develop HIT. 50% of these patients will develop thrombosis. Some may be asymptomatic. Increased awareness and a solid understanding of the risk factors and frequent monitoring of heparin-treated patients is key to preventing death and disability associated with heparin-induced thrombocytopenia.